So welcome again. I'm Dr. Suzanne Judd and the director of the Lister Hill Center for Health Policy. I'm delighted to have you all here today at today's webinar as we explore the ongoing research within the LGBTQ+ community here at UAB. Today's webinar is made possible by the Office of Public Health Practice, the Public Health Student Association, and the Lister Hill Center for Health Policy. Each of these sponsors is offering interesting and informative virtual events all semester long, so please be sure to check their websites for updates. Today, we are hearing from 3 researchers at UAB about their work within the LGBTQ+ communities. I'm going to briefly introduce them and then let each of them talk about the work that they do. I'll have a few questions for each of them, and then we'll move into audience Q&A. Dr. Ronit Elk is a professor in the Division of Gerontology, Geriatrics, and Palliative Care. Using community-based participatory research, her work focuses on partnering with underserved populations to create palliative care programs that are culturally based. She co-edited the book, Cancer in LGBT Communities, and served as co-editor for a special issue on cancer and LGBT health in the journal LGBT Health. Dr. Elk is currently conducting a series of CBPR-based studies in LGBT elders in Birmingham, in which she is mentoring 3 beginning investigators in conducting these studies. She collaborates with many other national LGBT health-focused researchers and has launched a large group of national researchers focused on older LGBTQ+ populations. Dr. Nicholas Van Wagener is the Associate Dean for Students in UAB's School of Medicine. He and his team provide programs and services in the areas of academic advising, career advising, professional and personal development, student health and wellness, student organizations and interest groups, and student leadership. In addition to his role as an instructor and associate dean, Van Wagener has a passion for research. He studies HIV and other STIs in at-risk populations with a focus on how societal variables influence a person's chance of infection. Dr. Olivia Van Gerwen completed her internal medicine residency and chief residency at Tulane University in New Orleans. She returned to Birmingham to pursue a fellowship in infectious diseases at UAB, which she completed in 2020. She is now a clinical instructor in the UAB Division of Infectious Diseases and a Health Services Outcomes and Effectiveness Research postdoc fellow. Her research focuses on STI prevention and sexual health promotion among transgender populations. Clinically, she enjoys providing sexual health care services to patients at the UAB gender health clinics, as well as patients living with HIV at the UAB 1917 clinic. So please join me in welcoming all of our speakers.
Thank you so much for the opportunity to participate in this. And it really is a pleasure. And thank you to everyone who is attending. As Dr. Jed mentioned, my name is Nick Van Wagener, and I am a physician in the Division of Infectious Diseases, Department of Medicine, of Internal Medicine. And in addition to that, I serve in the School of Medicine. And really what I'd like to do just for a few minutes is talk a little bit about some of the research that I've been involved with and that is ongoing at this point as it relates to LGBTQ+ populations. In addition to this research, another important research area for me is herpes simplex virus vaccines, specifically of the therapeutic type. And so maybe for another time, I'd be happy to talk with you about that. But where I'll start with this is that my real interest in sexual orientation and specifically looking at the intersectionality between sexual orientation and religion comes from personal experience. So I am gay, and I also grew up Mormon in the West. And so I grew up in a very strong faith-based environment. Which I very much appreciate and I'm glad for that experience. And what that experience did is I moved into my research, moved on in time and also started developing my research, was trying to really understand how variables interact with each other to influence our potential behaviors. And so with this background, my own personal experience, I became interested in looking at sexual orientation and specifically religion. As you know, we live in the southeastern United States in an area of the country that is highly religious and actually more religious than most other areas in the country. And so there is a strong impact of religion. As well, we also know that just like there are LGBTQ plus individuals everywhere, we have there are many people living in the South who are experiencing both living as I'm going to focus on LG or B for now, and also have strong influences of religion. And so I started looking at this from the context of health behavior and how potentially this interaction would impact health behavior. And because a lot of my research work was initially in HIV, I looked at the question or asked the question around how do sexual orientation and religion interact, and how are they associated with timing of presentation for care for HIV. If you'll go ahead and go to the next slide. What we know is that as HIV, sorry, go ahead and go back. Sorry, I put an animation in here. I shouldn't have probably done that. But what we basically looked at was timing of presentation for care for people with HIV. And we looked at it in the context of their sexual orientation and also whether or not they attended church. And what we observed that was among men who have sex with men who attended church, that they were more likely to enter care basically with lower CD4 counts. In other words, what this meant is that they were entering care at a later stage than other groups. We compared this for men who have sex with women, women who have sex with men and are diagnosed with HIV and did not see the same interaction. Therefore, we hypothesize that there is this relationship with these two variables. And in fact, that again, we, thinking a little bit further about potential causes, believe that there is some interaction between these two variables that leads to later care. Certainly, this could be related to stigma. Certainly, it could be related to if someone understands that a person has HIV, it may lead to outing that individual. Now, this initial work led to some other work that I have done since. And so if you'll go to the next slide now. Thanks so much. But one of the things that it brought up to me, and in part with working with LGBTQ plus populations in HIV care, is that there is so much stigma, as we all know, related to or concern from patients about sharing sexual orientation and gender identity, even with healthcare providers. And as I've contemplated on this, one of the things where I focused my efforts was looking at how we might create resources for accessing care for LGBTQ plus people. And so what I've been doing over the last several years is, along with the Division of Infectious Diseases and the Department of Family Medicine, we developed a sexual and gender health clinic at UAB Student Health, okay? At the UAB Student Health and Wellness Clinic. And so we're all working from the same framework, basically gender and sexual health are states of physical, emotional, mental, and social well-being in relation to gender and sexuality, respectively, or sexual orientation, respectively. And the goal of developing this clinic was actually to provide gender and sexual health services to all students in an inclusive, supportive, and respectful manner. With development of this clinic, our hope is that we are improving access to care for our LGBTQ plus students. So if you'll go to the next slide. And so we have ongoing research. The clinic has now been open for about 5 years. And the questions that we're asking and looking at is have we improved access? Are we seeing more individuals who are LGBTQ plus and who are seeking care with us? Not only have we improved access, but we're asking questions now, starting to look at qualitative research of how do we improve access? We have a clinic, but is it meeting the needs that we need to meet? And how can we do better? We are also looking at several outcomes, and we're looking at how access impacts outcomes, specifically for preventive health, specifically with STI screening as well as pre-exposure prophylaxis. Are we providing these services to more individuals? And if we're not, how do we improve that? Also, we're looking at how we're doing with diagnosis and treatment and the care of our LGBTQ+ students. And also, what is the impact on not only physical outcomes, but emotional outcomes for students who for whom we are providing gender affirming therapy. So I know that that's a very, very high level view of some of the things that we're doing. One of the things I will mention is that Andres Camino is one of our students and has been very instrumental in doing this work and has been an incredible researcher in helping us understand aspects of the care that we are providing to students. Again, I'm happy to talk more and more about this, but certainly want to leave time to learn from the other presenters. So thank you.
Hi, everyone. My name is Renate, and I do the study with Sarah Lapin. As I said, there are 3 beginning investigators. And as a old, wise woman, I love being able to mentor people who are excited about research and doing this kind of research. And we're focusing on LGBT elders, a sort of a broad definition of elders. Don't get upset if you're young or 50 and you get counted as elders, but more or less 50 to 60 and people who have serious illness. And so, you know, we have a large population of LGBT patients. And as any of you who've done any research in or even read articles, you know that there's lots of economic disparities, there's lots of physical and mental health. This is very, very broad, and so on, and the terrible discrimination that occurs. And those who are over 50 have got a higher prevalence of disabling chronic conditions. So one of the things I want to talk to you about is serious illness. Think about if you've been seriously ill or somebody you love has been very, very ill. We perceive illness, we perceive suffering, we perceive dying through our very own cultural lens. Let me explain a little bit more. So what kind of care we want, what kind of information we want, what kind of family involvement we want is very much dependent on our culture. So does, what do we talk about? Is it taboo to talk about death in some cultures? Is it talking about a time till death? It may not be appropriate. And then suffering, what it means and so on is different. And then who just makes the decisions? Is it God or is it medicine? Very tricky question in medical care. One that I hope one day that we'll have a better understanding about spirituality and religion in medical care. So I'm very interested in talking to you, Nicholas, afterwards. So here's the thing. The end-of-life care in the United States, or caring for people with serious illness, was actually developed based on values of the religious and cultural values of the white middle class. And these values actually do not, I put here politely, may not, but they certainly do not apply to other ethnic groups or to other cultural groups. And what happens is if we're not sensitive to, and we don't have respect for cultural differences and lived experiences, it's going to compromise the care for patients who are seriously ill and dying. And so it's been considered a public health crisis not having culturally competent end-of-life care in the US. In one of our other studies, we developed the first ever culturally based palliative care program, and that's for rural African Americans and rural whites, and that serves as a template, as a model for other studies. But up till 2016, there was no such thing. We don't have enough study focusing on LGBT elders' needs, preferences, what kind of issues they have with serious illness. And of course, we all know that care is provided within a healthcare system where staff are often uncomfortable with or discriminate against partners. There's a lot of literature on that, but I just wanted to share with you one study which literally came out last year, and this is in hospice and palliative care, the nicest people on this planet. And yet, people who were LGB, I think that a separate study with the trans group, they had significantly higher odds of having all kinds of discrimination. Like the decisions were disregarded, they were treated disrespectfully. Their partners, you know, often your partner is the person who has input into your care when you're so ill. They either weren't, they were denied access, which is illegal, or they had limited access, and so on. So here's what our goal was. What we're doing is to develop a palliative care program that's going to meet the unique needs and the values and the care preferences, medical and psychological and other spiritual care of white, African American, and Latinx LGBT groups. We do this by partnering with the community to find out their values, and the program's actually developed by the community, as I'll show you. We then want to train palliative care clinicians in this community developed program. Not easy. Thank God I have a wonderful partner who does this part, and then implement it at the UAB. And if we find that this is really going to be much more effective, it can serve as a first evidence-based program for older LGBT with serious illness that hopefully can be implemented in hospitals nationwide. That's those who do translational research know that that's a long journey, but having been in the field for a while, I can tell you that it is possible and it is happening. So the way we conduct our studies is in steps, which I'll show you in a sec. But the thing that I wanted to emphasize is we do it in community partners, with community partners at each and every step. Why? Because we use CBPR, and if those of you who are public health students know that this is a superb, wonderful, I can't say enough words about it, because it's a very much a social justice principle. It's not really a method, it's more like a philosophy and principles. And you have full and equal partnership with the community, and you build on the strength of the community. It's the community actually owns the process, very different to RCT kind of research, randomized controlled trial. And why do we partner? Obviously, because LGBT members know their community best. The program will represent the needs and values of the community. And when we do partner, we listen to and hear to whatever the group says. And then we follow the recommendations. Even if we hadn't planned that, too bad, revise. It's what the community wants, it's what we do. So let me go through the phases quickly. So the first thing before we start the study is we convene what's called a CAG, which is Community Advisory Group. It's the key to all of this. We have a community advisory group. At the moment, we're going to have separate advisory groups for lesbian, bisexual women, gay and bisexual men, and transgender men and women, and gender non-conforming groups. Then we have separate focus groups for each of the groups. Why focus? Why can't we do it together? Well, because we really want people to feel that they're able to express the needs and the concerns of each group. But the beauty of it is we all come together in phase 2, all the community advisory groups, and then the community advisory group creates this program. All I do is facilitate it, but the CAG itself makes the recommendations. This is the part that I said wasn't such fun. I mean, it's nice to see when clinicians are trained, but it's challenging. And I have a wonderfully patient collaborator, Dr. Michael Barnett, and he trains the clinicians. And then we'll implement it at UAB to see how it goes. Finally, we'll have to do a randomized controlled trial to compare this program with other programs. And I mean, obviously we know that it's going to be much more effective if you respect people and you value people. What do you expect? But anyway, you have to do it. And then we hope that it'll be replicated. My other studies in developing culturally based programs are being replicated. So I do feel that this can happen. So let me tell you where we are in the study. Where we started, remember I said with separate groups. So the lesbian bisexual women group, in the pre-phase 1, before we start, we convened our advisory group members. There are 8 members, 4 African-American, 4 are white. Everybody has an equal voice. I said we have Latinx people too. However, not enough of that age group in Birmingham. So we're partnering with a colleague in New Mexico, and she's doing the parallel study with the Latinx groups. We've held many meetings. I think it's 9, might be more. And each meeting, we received recommendations on all aspects of the next phase, which is the focus groups. Here are the flyers that were created. Based on all the different recommendations that were given, we had to revise the protocol, which means going back to the IRB. And we're now currently recruiting for focus group members. So those of you who see it, please help us get the number of people we need for the focus groups. We've hired and trained focus group facilitators. The group said, African-American members said that they wanted separate focus groups so that people will feel very comfortable and safe. And so we hired an African-American facilitator and did all the training. And we have almost enough for one of the focus groups, and they'll start in April. For the gay and bisexual men, we're going to apply for funding from a community fund here in Birmingham to conduct the parallel study, exactly the same, the community advisory group and the phase 1, and the transgender men and women and gender non-conforming. Dr. Clevenger is the other young person. She's, oops, I've forgotten. She's a PhD psychologist faculty member here. I've forgotten which department. I guess it's arts and sciences. And she's been funded to conduct a parallel study, and we're going to start that in April. So, you know, we have a lot of balls juggling at the same time. And then what do we do about developing the program? I'm going to apply to the NIH. It's called an R21. It's a small grant to develop the program. It takes a huge amount of time because everybody in the community gets input. We train the clinicians who are seriously ill. Takes time because it's not like everybody says, oh, goody, I want to know. No, they don't. There's a lot of pushback. And then we'll implement the program that the community has developed at UAB and test the feasibility. And then in following years, I'm going to apply for an R01, which is where you have to do the RCT. I think we were asked to see about our partnership with other LGBT researchers. So for this study, as I said, I have a collaborator at University of New Mexico, and she's doing the exact same thing with Latinx patients. We've developed a nationwide group of researchers who are focusing on older LGBT, and there's already 20. At least 20, and we meet monthly or bi-monthly to see, you know, what the gaps are and to write collaborative grants and papers. When I say gaps, I can tell you that when you go to the NIH, 90 or more than 90% of the funding that's given to LGBT focuses on HIV and AIDS, which I do not begrudge at all. However, when I think of what we had to do to get it, however, it's very important. There are lots of other needs in the LGBT community, particularly the older community, and those must be addressed as well. I've recently been involved in the collaboration with cancer centers who are looking at sexual and gender minority, their goal is to collect SOGI data, sexual orientation, gender identity data. Don't ask me, that's a whole long issue that should have been solved a long time ago, but as with all these health equity issues, needs people to push it to get it to going. Our cancer center didn't do it this time, but we are. If they get this funding, I'm a consultant on these. If they get the funding, then we'll do other bigger things. And then there's a lovely group that I'm also a consultant on, which are with SGM research, sexual and gender minority focused researchers. And what they've developed is we developed a training, a one-day training. It's already, people have applied and got funding to go to it. And it's all different kinds of research methods. Of course, I love the CBPR methods, there's EPI methods and so on. And it's all focused on, if you want to focus on sexual and gender minority research, this is a wonderful place to start. Now, as I said, it started, but don't worry, the group has applied for a second R25, which will be able to do it in multiple years. And as soon as that comes out, I'll let you know if anybody wants to participate in that. And as for mentoring, yes, always possible. And we do have a student who's very much participates in our advisory groups, but there are possibilities for other students at certain times. Okay, that's it. I'll stop now and answer questions later.
Excellent. Thank you so much for that. And now for our final presenter.
I'm Olivia Van Gerwen. As Dr. Judd said, I don't have any slides because I'm coming to you from the hospital, but I have some slides in front of me on another computer. So I'm going to just talk through some of my work. I'm an early stage investigator in the Division of Infectious Diseases, and I'm still doing a postdoctoral fellowship. So I'm a little earlier in my career, but my area of interest is largely transgender sexual health promotion and STI prevention, both for transgender men, transgender women, and also for gender nonconforming populations. And like Nick had mentioned in his talk, my interest in this area came from some personal clinical experiences that I had as a resident. I was living in New Orleans doing my medicine training, and my outpatient clinic that I was working in it was basically a resident run initiative, and we began providing hormone care and transgender affirming care to the patients in our area who had no insurance or who were underinsured, because in the city there weren't a lot of opportunities for patients who needed those services. So we began taking care of these patients, and this was a population I was not very familiar with from a doctoring standpoint. And I learned a lot in that time about a lot of the disparities faced by transgender individuals, and in particular, the sexual health disparities that are rampant in all LGBTQ plus populations, but the transgender folks are certainly experiencing a lot of sexual health disparities. And as others have mentioned, in our area of infectious diseases, a lot of the focus, rightfully so, is on HIV, but there are many sexual health disparities outside of the realm of HIV that this population is faced by, such as STIs outside of HIV, and then other sexual health issues that are more comprehensive. And one of my goals as a researcher moving forward is to begin thinking of sexual health in a more comprehensive way for our transgender individuals, given the unique population that they are in terms of the medications that they take and sometimes surgeries that they have for their gender affirmation process. So I'll talk about a couple of my projects that I've been involved in as a fellow, and then moving forward into a junior faculty member. All of this is kind of in hopes of applying for a K-23 award, which I know we've done the NIH alphabet soup today through some of the presenters. And I think that, a K-23 is the career development award that a lot of investigators begin with. And it is a research project paired with a career development plan. So I'm doing all of my preliminary research in preparation for applying for that type of award. So I was awarded a pilot grant through the UAB Center for AIDS Research last year, and I was interested in investigating the barriers that transgender women in our area faced with regard to their knowledge of, excuse me, sorry, I'm in the hospital on my phone, based on the issues that they have with their knowledge of HIV risk, as well as their knowledge of different HIV prevention strategies and how those relate to their gender identity and how those relate to their population. And in particular, I wanted to explore this in the Southeast because, as we've mentioned, we have a very unique cultural environment here in the Southeast compared to other parts of the country where I think a lot more of this research happens. In the coastal cities of New York and LA and San Francisco, there's a very different cultural vibe for LGBT individuals than in the Deep South. So we did some focus groups where we recruited transgender women in the Birmingham area. And the award actually began in March of 2020. So instead of being able to do in-person focus groups as we had planned, we had to pivot and do virtual focus groups via Zoom with these women. Which was something we were a little hesitant about at first, but it actually turned out to be a fantastic way, I think, to engage this population because many of them felt safer engaging with us via virtual focus group. as they didn't have to like come to a central location that they maybe weren't familiar with. And then they had the opportunity to have some anonymity if they chose to. We allowed them to use an alias and turn their video off if they liked. So I thought that was a really interesting pivot that we had to make that actually turned out to be a really positive thing. So we discussed the different, we discussed with them, you know, what their perceptions were with the struggles of transgender women with regard to HIV prevention and with PrEP uptake. Transgender women are at very high risk for HIV in this country and worldwide, but PrEP uptake, which is, you know, the pill, for those of you who don't know, it's a pill that people can take to prevent the acquisition of HIV. And it's not really been as popular, and as the uptake has not been as strong among transgender women as other populations who it's been kind of targeted toward. So we asked them why that is, and especially in the Southeast where we see so much HIV and we also have a fairly large transgender population, why that might be happening. And so through our discussions with these individuals, we had 17 women in our study that we talked to through 4 different focus groups. They were average age of 28, and it was half African-American, half white. We didn't have any Latinx women in our group. And it was very interesting. You know, they all identified, they had a very diverse array of sexual orientations, I should say. They had a lot of different genders of their sexual partners, and then they also had lots of different ways that they identified with their sexual orientation. Of the women we talked to, 15 of the 17 had heard of PrEP, but only 1 of all of them had ever taken it, at least even once. So we asked them, what are your barriers to, why do people not take PrEP in your community? And a lot of them identified some things that we know in the literature from other parts of the country. But the overtones that we got from them were that in the South, it's kind of amplified. They mentioned that they had a lot of issues with getting trans-affirming care in places where they felt safe, and having trouble, frankly, finding physicians or providers who were able to one, provide them with the services that they needed, and 2, deliver those services in a way that was affirming and comfortable and safe for them. And then they also cited a lot of hesitance with the potential for the medication, the PrEP medication, interacting with their hormone therapy. Some of the quotes from the women were really kind of, to summarize, they said, my main priority with my health is my transition and being my authentic self, and anything that's going to derail that process, I don't want to do. And I don't really, a lot of them said, you know, it doesn't really matter to me how beneficial this other medicine can be if it's going to be detrimental to this main priority of mine, which is completely understandable. And we expected to hear that from them. And the other thing that I thought was really carried from group to group was a lot of these women who were either not in relationships, who were in self-identified lesbian relationships, a lot of these women who were, you know, not the typical kind of quote unquote stereotype that a lot of people in the lay public have for transgender individuals. Most of these people were not having sex with cisgender men or other transgender women. They had many different sexual orientations and sexual behaviors. And they felt that in PrEP advertising, as well as kind of the general discourse around PrEP and HIV, there's a conflation with transgender identity and HIV risk. And people feel that they kind of become that identity. And regardless of what they're actually doing and how they're actually behaving and what their actual interactions are in their sexual lives, they're being pigeonholed as a high-risk person or a sex worker or something in that realm. And that was very, you know, that had put a bad taste in a lot of people's mouths, which is completely understandable. So that was one of our major findings. And this really was some preliminary qualitative work that we're hoping to use, like I said, in future research endeavors to form patient-centered healthcare intervention development, you know, research projects that can lead to practice-changing interventions that help promote the sexual health of transgender people and people of all gender identities in a broader sense, and speak to them, you know, based on who they are as far as their behaviors and what their risks are as an individual, as opposed to looking at them as a population and kind of pigeonholing them there. So that's one study that I've done. And I I'm happy to answer any other questions. And again, I apologize for not having any slides, but I am happy to talk about any questions anybody has.
No, that's great. Don't apologize at all. I'm going to kick us off with some questions, starting first with a kind of a theme that's going on in the chat. And any one of you, please feel free to answer. There are a lot of questions around intersectionality, questions around, maybe you've got a racial and a religious idea or identity. Maybe you've also got a racial and a ethnic identity. So talk to us a little bit about intersectionality in this field.
That's interesting, if you don't mind me jumping in. I just was asked to write an editorial for the journal Cancer, and it was based on an article on sexual and gender minority women who are African American and the importance of intersectionality. And so my whole editorial was on the importance of intersectionality and how we have so long in the field, I was actually talking in the cancer field, but it's fine in all fields, we focused on the minority stress model, which is very, very important, stress and resilience. It's very important. I'm not saying it's invalid, but we haven't done enough to look at the intersectionality. And it's actually the African-American women who have brought this to us, and something that we need to do much more of. I'll be glad to share that. Oh no, I can't share it yet. It's under review, the editorial. But once it's, once it's published, if anyone's interested. Thank you for that question.
Yeah, that's great. That's great. Thanks. Any other thoughts about that?
Yeah, so it's a great question. And one of the things that I've learned, and maybe this is more in clinical practice, that has informed research, and it's something that Libby mentioned earlier. And that is now when I go into a patient room and I'm interacting with an individual, I think that it's important to recognize that all of those factors are at play in that conversation with a patient. And that in order to create an environment that is respectful of the individual, that is inclusive, it's important to allow them to share with me rather than me make any sort of assumptions about their wishes, about their care, about who they are, their identity in any way, shape, or form. And so coming back to the original question, I think that intersectionality is critical. And I think that it is so complex because there are so many different variables that make us up into who we are, that we do need to understand them better and how they interact with each other. And from a practical standpoint of caring for patients, I think that it's important that we walk in sort of with a clean slate and allow the individual to share with us their specific needs, their goals, who they are, and be able to define for us what those intersectionalities mean for them.
So we've got a couple of questions that we thought about as a committee ahead of time that we had for you as well. Currently in the School of Public Health, we have an effort to establish an endowed professorship in LGBTQ plus health studies. And what do you think is missing today in the LGBTQ plus research in either medicine or public health? And I'd love to have all three of you answer this one.
I mean, personally, and Nick probably will tag onto this as well. I feel that in infectious diseases, we see a lot of, bias toward HIV. And so I think focusing, like I had mentioned, my area is more on overall sexual health and issues faced that are beyond, infections that people get. Because I think that, again, kind of perpetuates this dysphoria and the stigma that people may find, I guess, augments their already, they already feel like they don't want to talk to people who are researchers or who are in medicine. If you come to them and say, I want to talk to you about a study about HIV because you're a trans woman, that is something that we met a lot of resistance with in our study. People felt that we were pigeonholing them, as I mentioned earlier. And so I think in the broad sense, more comprehensive attempts to understand how sexual minority groups and LGBTQ populations are experiencing various disease states is really important. And so I was really excited to hear Dr. Elk's work because it's so much outside of what Nick and I generally see in the ID world. So talking about end of life care is such an amazing thing to focus on. So I think more research in that area is really important.
Yeah, thank you. Dr. Elk or Dr. von Wagener?
I think a more comprehensive understanding of the whole life experience and addressing and basing our research in that realm. And again, you know, working in ID, and I started in sexually transmitted infections and studying HIV, and so as a natural, I think, extension of that, that is some of the space that I live in. But as Libby has pointed out, what does it mean to be sexually healthy? But more importantly, what does it just mean to be healthy and someone who is LGBTQ plus? What does that mean? And how do we provide better care or for sexual minorities? So I think that expansion is really the key that I would echo.
If you look at the health, you know, I was participated, this is important, I was participated in a panel with NIH, the SGM office, the Sexual and Gender Minority Office, wonderful, all these wonderful, the heads of, or associate heads of each of the departments, I mean, the different, the National Institute of Aging and this one and you know, all of them came there and they were all proud and said, oh, in my portfolio, that means I am funding, look how many people I'm funding who are LGBT, and just about all the studies are HIV. And I mean, I wasn't allowed to talk because it was a sort of one of these kind of things. And I was like dying there. Fortunately, there's opportunities to give input because HIV is not the only problem that the LGBT community face. I mean, homelessness for the young people is key. And thank God there are people who are stepping up with, you know, building services, at least start with something. And for the elders who are so afraid when they get so ill, who's going to take care of them? They can't go into a nursing home because they're going to have to go back into the closet, and all the serious ill health. And as for women who have lesbian women who have a much higher risk of cancer and several other diseases. And then I'm so glad, Olivia, I'll be contacting you afterwards because everybody says, oh, well, we'll get to the trans group later. We'll get to that. That's so complicated. Well, they're human beings too. And their needs are huge. And their understanding of them is abysmal. There's a wonderful person who I really tried to apply for this position for this position. Dr. Irwin knows it because she studies trans health and especially minority trans population. And I mean, in our society, if we want to look at a group that's sort of like the lowest of the lowest of the lowest, minority trans group. Okay, that's the ones, let's go kill them. I mean, it's horrific what our society has accepted. So yes, there's lots of issues that can be addressed. As for the SOGI data, the collection of that data, there's some laws that say you're supposed to have it. And so, okay, everybody quickly puts it in their medical records, but then in the end, it's not, oh, well, it's very difficult or our patients don't want to or something. And it turns out it's the leadership that really doesn't want to do it. And that is going to help us to be able to determine which group has what. I mean, the epidemiologists are salivating. They're going crazy because they cannot answer these questions.
Yeah, I
Please
just
don't
want
ask me to go on. There's just so much that the chair could, I mean, this position could do.
Yeah, I think you bring up a really good point about SOGI data. I think there are so many shortcomings with how we collect, both in the clinical, like in the clinical setting, your point is exactly right. We don't, as clinicians, appropriately document these things so that research can be done to understand the epidemiologic problems faced by these groups. But I think also the nature of data collection is really difficult in a group that is not necessarily wanting to be defined as far as like, you know, a binary definition of who they are in a sexual identity or a gender identity. So I think
yes.
Another shortcoming is, you know, folks who identify as non-binary, folks who identify as fluid, like how to collect this data is such a ripe area. I think
they're already doing it. I'm telling you,
it's fascinating.
The other thing is, why aren't people coming out to their healthcare clinicians? Let's see. How difficult could that be? They're not coming out because the healthcare system is not embracing them. Well, thank goodness UAB has the HEI, a very high score. Nevertheless, there is still so much prejudice and so much discrimination, particularly if you're minority. I mean, that's what that paper is in the Cancer Journal. And so whoever's doing health systems work and trying to change policy, please, I'll kiss your feet. It's so important to do that work so that we can change systems. I saw there was a question somebody asked about some law in Alabama it's felony for medical professionals to treat transgender minors under the age of 19. I had no idea. I mean, isn't that something that's huge that needs to be examined?
Yeah, and we had a speaker earlier in January that was talking about this very process as our legislators were debating it, the question around puberty blockers. And, he did a really nice job explaining that for some of these kids, puberty is incredibly traumatic. And puberty blockers allow them to take more time. And that's one of the things that Alabama was passing laws on. Our legislators are passing laws on right now. So
today.
You noticed that comment. He really articulated the issues very well. And it's interesting. We had another person talk about healthcare, and one of the concerns he does transgender medicine over in Atlanta. And he was saying he's frustrated in his own clinic because the forms are not patient-centered, patient-forward. You have to declare a gender, or you're not allowed to give your pronouns. And we've got someone here who asked the question about having a hard time identifying a physician or a healthcare provider that will be sensitive to their needs. Could each of you talk about that a little?
I'll make a quick plug. So UAB actually just recently in July of 2020 opened a gender health clinic. So we're able to see patients there. It's generally for people who are transgender or gender nonconforming. So overall LGBT healthcare, there are other places in town that are definitely options. But for people in that identify in that way, the gender health clinic aims to provide comprehensive multidisciplinary care. So we have endocrinologists, mental health professionals, and then surgery subspecialties. We have plastic surgeons and urologists, and you can see all of those providers in this one clinic too. And then I also provide PrEP and do sexual health care over there. So if you are going there, it's a group of people who are aiming to care for transgender and non-binary individuals. So we try our best to be affirming and kind and respectful. And so I think that's a great option for people in that group. And then I don't know if Nick wants to comment on the student health clinic.
Sure, I can just comment briefly on that. But just a shout out to Libby. The work that she's done with her clinic is really remarkable, and I think is providing a service that has been absent and needed for a long period of time. So really, thank you to you, Libby, for your work in that. The Sexual and Gender Health Clinic at Student Health was developed primarily, as I said before, it is to provide sexual health services and gender health services to all students. But really the major focus of that was to provide services to our LGBTQ plus students and provide a clinic where they could hopefully feel comfortable. They would feel that the care that they are receiving is by individuals who have expertise and who can be supportive of their needs. And what we've observed is that we have seen a large increase in the number of students who are seeking care. Alas, the limitation of this particular clinic is that it is specifically for students. But an interesting thing that we've observed and that we're sort of evaluating the data on right now is that having such a sexual health clinic embedded in a regular health clinic actually seems to have impact on other providers. And the clinic itself, meaning from the front desk all the way to the back, in ensuring that patients who are presenting have the experience that they should have all along the way. And so coming to the question again, I think that opportunities to have providers embedded in clinics, even if not every provider is yet comfortable or understanding, knowledgeable about LGBTQ plus health needs, that is a step forward with that. You also mentioned in the chat, and I think it is important to talk a little bit about our colleagues in the community who are doing remarkable work as well. Magic City is done incredible work in providing care for LGBTQ plus people.
That's great. That's great. Moving from the clinic back into research, do you know of any funding mechanisms specific to funding research in the LGBTQ plus populations?
Oh, wonderful. After I told you that the NIH only, yes, if it's on HIV. If not, it's still the NIH and we still have to apply there because we have to put pressure on them. And there's an office for SGM research. So hopefully that will change in the next 10 years or so. There are small grants that one can apply for from different foundations, for different kinds of pilot studies. There's one even in Birmingham, I've forgotten what it's called. There's one that we're going to apply for, but those are more for programs. So if you wanted to start a program in X, in whatever that focuses on the LGBT community in Birmingham, that's a really good place. I'm sure there's other foundations.
I've been kind of shopping around where my K application fits best. And I've gotten a lot of, because I'm doing, sexual health, STI focused research with trans individuals. And I really want to stay away from, siloing off HIV from all of that, because HIV care is a part of sexual health, not the end all be all. And so the NIMHD, the Health Disparities Group, has been very receptive to that. So they are actually, I think, a good place to look for opportunities. And what else was I going to say? Nick and I actually just submitted a R21 with some of our collaborators about bacterial vaginosis research in transgender men. So it was a ID focused study, but it was not HIV focused. And it got reviewed. It didn't get funded, but it got a competitive score. So I think there's more opportunities in the NIH coming around. It was for a SGM group, RFA.
It will change. It's just frustrating that it's taken so many years. And I personally know of so many superb researchers who should have been funded umpteen times, and now has come to the end of her career and she's given up. It's sad to see that. And but for the younger people, the beginning investigators, we're here to mentor you. Don't jump into any NIH grant unless you have a mentor, please. No, it's too many rules.
Absolutely. And I just want to let folks know that the study section that I sit on is called Healthcare and Health Disparities. It used to be called Health Disparities, Equity and Promotion. And about 50% of the grants we review are LGBTQ+.
Yes.
And they're across the spectrum, actually very few related to HIV. I think the HIV
Which institute is it?
It's a cross-institute study section, but it's a good study section to send your research to.
Can you send the name again, please?
Yeah, absolutely. I'll send that.
Perfect.
That's the bulk of what we review.
Perfect.
Which is very interesting. Well, we're getting close to the end of the hour. And as I'm looking through the comments in the chat, one of the big themes that everybody's asking is, how can I work with you all?
I put my email in there. I put my email in there. I just want to say, for the person whose primary care physician left and it's hard to find another one, in Atlanta, where I sort of semi-live, there is the LGBT organization created a gray and yellow pages thing that you could look through and see who's the doctors that I can trust. I wish there was something like that here, but if there isn't, if you guys know who a primary care physician this person can go to, it's horrible not to.
Yeah, absolutely. It sounds like there's a real need in terms of information sharing for people so they can identify physicians that will listen to their needs.
Mostly that they will not judge them.
Exactly.
Another thing that I'll mention, and this is more in the realm, but I think that education leads to research is one of the things that Libby and I have the opportunity to work with as well, is through the CDC with the HIV STI Prevention Training Center. And again, recognizing HIV and STIs, but a lot of the work that we're being asked to do is in the realm of education and creating a more, a better interaction between healthcare providers and with patients, and creating an environment where folks want to come and access care. And so also, if you have an interest in that space as well, I'd love to be able to talk with you about that. It covers 5 states in the Southeast, so a unique region to provide LGBTQ plus education to healthcare providers to help them in their care.
And we don't have a whole lot of time, but if anybody wants to talk about like upcoming projects or things that are going on, you know, you can get our email address from the hosts of this webinar. And I know that I would be happy to talk to anybody on an individual basis about projects going on.
Thank you to Rodney for the tip in there that there's a search feature in the UAB physician directory that you can look for the LGBTQ tag. That might be helpful for some folks. And
thanks for not telling me. Fantastic.
yeah, that's wonderful news.
Fantastic.
I just want to thank our panelists. I think for those of you that are out there listening, you heard them say they're happy to work with you. So please continue this conversation. We really want to see LGBTQ plus research grow at UAB. And it's exciting to see so many folks interested. So thank you again, panelists, and thank you attendees for being here. We really appreciate all of you.